Tom's not gonna do it.
I got my scenarios and seconds done this morning.
I got mine done yesterday afternoon. I don't know how loud that is.
I got my 2 Relias that are due done this morning.
I've been working on evaluations.
I'm trying to decide if I want to go home and listen to that burn thing or do it here.
Did anyone listen yesterday?
Huh?
Did anyone listen
We
yesterday?
did.
Bree did? Was it good?
Who said it was?
Something loud.
I'm just gonna put my headphones on
Okay, perfect.
and we can.
Okay, it looks like it is noon. We will go ahead and get started. Thank you, everybody, for joining us for our 3rd session of the Capture Falls cohort. Today, we're going to talk about the information from the gap analysis for those of you that filled it out. Those of you that we have not received it from, you should be receiving or have received an email, just a reminder. If you can get that information in as soon as possible, then we can use that to better guide the upcoming work. Again, as always, if you wouldn't mind putting your name and organization in the chat, just helps us better get a handle on everybody that's joining us. Those of you that are also on Zoom, please remember to mute yourself and keep that muted unless you want to answer questions, ask questions, those kinds of things, so that it's not distracting for everyone else. And then I sent out a link to the first 2 sessions. Those recordings are on the NHA website, and my apologies, but I don't think I put the slides on there. So I will get with Brian yet this week and get the slides added to those links for recording so that everyone has that information, or if they have other team members that weren't able to join us for the live session, they can get that. Otherwise, as far as for me, I think I'm going to hand it off to the capture team and let them go to work. So Dawn, are you the one?
I'll be Dawn, and this is Vicki. I'll kick us off and then hand over to Dawn, and then Dawn will hand back over to me.
No worries.
Okay, well, Vicki and Dawn.
What time tomorrow?
All right, thanks, Dana. So we are on session 3. Believe it or not, we're in our 3rd session. As Dana mentioned, today we will we'll give you just a really high-level overview of the gap analysis findings, and then we'll focus most of our time on education on auditing process measures, as that was something that the main area that popped up from the gap analysis as an area of need. So we want to give a big thank you to everyone who completed the gap analysis for us. As of August 24th, when we did kind of a final pull of the data for synthesis for purposes for this cohort, we had 20 hospitals in the cohort complete the gap analysis. So thank you very much for doing that. We strongly encourage those who haven't yet completed it to still do so. It's a really informative overview of your fall risk reduction program, and you can benefit from it by helping you identify strengths and areas that you can focus on for improvement. So the link remains open for you to complete the gap analysis, and we'll take another look at the data again, once everyone who wishes to submit it has had a chance to complete it. To give you a high-level overview, one of the things we had asked you to do when starting with us in the H grade cohort is to put together a team that you'll work with within our 90-day rapid cycle improvement process. And 95% of our 20 hospital respondents have done so. So we can check that one off the list. We also asked a question about, when was the most recent time you completed a gap analysis? And only 10% of our respondents had completed a gap analysis within the past 2 years. So the exercise of completing a gap analysis is good for the benefit of our cohort, but also good for the benefit of your own improvement efforts. And then just about half reported that they had some sort of current action plan for their fall risk program. So how we used the results of the gap analysis to inform our direction moving forward for the age grid cohort. What we did is we reviewed all of the data, and we focused on, in particular, on the questions about the fall risk reduction activities that your hospital either doesn't perform or does perform. And we gave you 3 response options for those questions. You could say, no, our hospital doesn't do this activity. You could say yes, but our hospital could do this activity better. Or you could say yes, and our hospital did this activity well. So to determine the opportunities for improvement for the cohort, what we did is we took a look, we kind of combined those who responded, no, our hospital doesn't do this activity, and those responses where it was yes, but we could do this better, to help us identify where there was an opportunity for improvement. You can use the same type of approach as you reflect on your own hospitals and analysis areas to help you identify areas where you could focus some improvement efforts but also areas that you think you're doing well, where you can continue to sustain the practices that you're already doing. So what did we learn? So the following areas listed on the slide were identified as those where there was the greatest opportunity for improvement across all the respondents from our cohort. Basically the greatest need. So again, hospitals that either hadn't adopted this practice yet or have it in place, but they think it's something that could be done better. So the three areas with the greatest opportunity for improvement were auditing fall risk reduction practices, conducting post-fall huddles, and conducting some sort of post-fall clinical assessment. So for auditing fall risk reduction practices, what we found was that 70% of our 20 hospital respondents felt that they could have some improvement in conducting audits to monitor adherence to fall risk reduction practices. And 75% indicated an opportunity for improvement to communicate the results of the audits back to the staff. We saw somewhat similar percentages for the post-fall huddle component. So about 65% felt there was an opportunity for improvement to adopt post-fall huddle tools and processes. 75% felt like there was an opportunity for improvement on educating staff to do huddles. And then 65% felt like there was an opportunity for improvement to ensure that we're actually conducting post-fall huddles after a patient fall. And then the third area that kind of emerged from our top three was the post-fall clinical assessment. So 60% felt there was an opportunity to improve on adopting a post-fall clinical assessment protocol. 65% felt there was an opportunity to improve on educating staff to use the post-fall clinical assessment protocol. And then another 60% felt there was an opportunity to improve in actually utilizing or following through with a post-fall clinical assessment protocol after a patient fall. And so these were the top three areas that emerged as areas with the greatest opportunity for improvement. So this doesn't mean that there weren't any other areas indicated from the gap analysis as areas for improvement for hospitals in the cohort, both individually or in aggregate. These were simply the ones that emerged as most in need for improvement across the cohort that we can focus on during the cohort timeframe. We'll continue to review the results and we'll revisit the rest of the gap analysis information that we have, and then think about how we can continue to support your efforts for improvement in other areas at a later date. So in addition to what we'll focus on in the age grade cohort, which our topic today will be auditing. And we also encourage you to further explore your own hospital's individual gap analysis results. And just want to remind you of all the resources that we shared during our last meeting during session 2 that are available on our Capture Falls roadmap. Those are things you can explore, and look at now for other areas that were identified as of great need for you. But our focus for today, and consistent with the top area for opportunity for improvement, will be on auditing fall risk reduction practices. So with that, I'm going to hand it back over to Dawn to kick us off as we talk about best practices for auditing fall risk reduction practices.
Okay, thank you, Vicki. So auditing emerged as one of the top things that people felt that they needed to improve upon. And that's great because it's also one that we think is going to be very feasible to improve upon in this short 3-month rapid cycle. So this slide here just basically reiterates what Vicki had just commented on about 70% of hospitals needing some or having some room for improvement on auditing. And this breaks it down a little bit more. Of the 20 that responded, 30% of you are doing audits and actually you felt like you were doing them fairly well. We still hope that maybe you'll be able to pick up some things that you could still learn and improve upon today. Maybe think about those audits a little bit differently perhaps after today. 40% of you are doing audits, but again, felt that there was room for improvement, and 30% of you haven't been doing audits at all yet. Auditing is something that months ago, when we were first talking with Dana about doing this programming, was something that we had thought of immediately, even before we saw the results of the gap analysis. So it's very fortuitous that that's something that you feel like you need. And it was also something that we felt was important to provide some education on. Auditing is something, we're going to be presenting it in terms of the context of fall risk reduction, because this is the falls cohort, but it's a strategy that we hope that you could potentially generalize to other quality improvement initiatives in your hospitals down the road. It's just specifically what you would be auditing is going to vary based on whatever that quality and patient safety problem might be. Okay. So again, we're hoping that you're able to generalize this information. The second thing is because this is a 3-month rapid cycle improvement period, it's also something that seems like it would be feasible to achieve. So the auditing itself might be something that you want to improve upon, or you can use auditing to kind of establish a baseline and then try to make some changes and then monitor or measure for improvement down the road, like say by November. And so we can do a PDSA cycle to conduct auditing, or we can use auditing as a tool to collect data in our PDSA cycle. So either way, from that standpoint, this is a valuable and feasible topic to cover, given the focused nature of this quality improvement initiative. Okay. The other thing is that auditing by its nature is going to measure structures and processes for quality improvement. So, fall rates ultimately is, that's, to be honest, that's what we care about. We don't want our patients falling. We don't want people to get hurt when they fall either. But sometimes we can be doing everything right and somebody still falls. And sometimes we can be doing everything wrong and nobody is falling. And so auditing gives us a chance to kind of see how are we doing with our policies and procedures, following those policies and procedures before the issue moves too far downstream and actually influences falls. And so it's a way to measure how good your fall risk reduction program is without having to wait so far downstream for those actual fall rates. So it gives us a little bit of an earlier window into how successful we actually are being. Okay, so that's just a little bit again about why we are doing this. We've got several slides that kind of gets into the nuts and bolts of what you should audit, who should do it, when, how many patients, that sort of thing. But to set the stage, I'm going to actually turn over the mic to Amber Caven for a few minutes, and she is going to share some of her own personal experience conducting auditing. So Amber, if you want to go ahead and introduce yourself and share your story, that would be great.
Yeah, thanks, Dawn. My name's Amber Cavan. I'm working with Dana as an HQIC Quality and Performance Improvement Advisor here with the NHA. So I'm excited to work with all of you guys throughout all of the learning cohorts that are coming up. But I just wanted to share some of my personal experiences with the auditing, because we all know that it's not just falls that we need to audit. There's lots of different performance improvement projects that can benefit from auditing. And I've been there, done that, and have learned a lot. So just quickly, just wanted to touch base on my experiences with auditing. So of course, you first identify an area for improvement, whatever project you're working on. You want to work with all of your teams, all of your staff to create that workflow or whatever change that you would like to implement. And of course, I also just want to throw in that it's important to get everyone's feedback so they feel engaged and they're empowered to help with improving outcomes. So once you make that change, it's important to audit just to make sure that the change that has been implemented is being followed through with. I know that there's a lot of different pieces to the puzzle, so just monitoring that change and making sure that what you guys are looking to happen is happening. So one thing that I just wanted to mention is who does the audits? Is it the nurse manager? Is it performance improvement? Is it the quality people? Is it frontline staff? So I think it's different for each facility. And I think that I personally have had most success with the frontline staff doing their own audits to kind of have that peer-to-peer engagement and feedback from other peers. I know oftentimes it's, well, they're just critiquing my charting, or they're just trying to find little things that I did wrong. So if you have that peer-to-peer feedback, I think that is really valuable, and it empowers that frontline nursing staff or frontline staff, whoever it may be, to kind of engage in the change and see the improvement outcomes. So another thing that I know that the Capture Falls team is gonna touch base on is, how do you audit? How often do you audit? What are you auditing? So I just kind of wanted to throw in that I think from my personal experience, having that frontline staff empowered to audit their own charts and give that feedback to their managers and their peers is something that's really important. And then of course, once you audit for so long and you make that change, or that whatever intervention you were looking to create, just to share the compliance rates, to share the improvements, be transparent with your staff is definitely something that will keep your staff engaged and help be successful. So that's all I have, Dawn. Thank you.
Thank you. So Amber touched on, we couldn't have set that up better. She touched on several things that we're going to be sharing with you, some information that is from some pretty reputable sources, recommendations for auditing, plus also some real world experience and anecdotal evidence that we have learned over the years with hospitals who've worked with the Capture Falls project. And so, you know, kind of some of the things I heard Amber just say about, you know, getting frontline staff involved and engaged to kind of create ownership and buy-in is a great idea. Making sure you share the results back with the staff is important as well. And the other thing I heard you say, Amber, that is again foreshadowing something that we're going to talk about is, you know, in terms of what to audit. A lot of times you want to audit something that you're kind of a new initiative or a new policy that you're rolling out. You educate your staff and you want to make sure that that's sticking. Well, you need to check in and see if it's actually happening, and the auditing can kind of help hardwire that. And so we'll be kind of touching back on those issues and a few more things on these next several slides.
Dawn, we have a question in the chat. I think is probably directed to Amber. The question was about doing electronic or paper auditing. Amber, I don't know if you want to comment on what your experience was with auditing and if it was electronic or paper.
I've done both. Oftentimes it was paper, but something that I have personal experience with is doing like a chart check at the end of every shift, just to touch the things that you're working on. So it was like, for example, it addressed, did you chart I's and O's? Did you chart a fall risk? Did you check all your meds? Just a checklist kind of, but it was, the expectation was to fill it out after every shift, just as a reminder. So that is kind of auditing yourself, and then someone else could audit if that chart check was being completed. So oftentimes it was paper, but that was an example of an electronic version.
Okay. The kind of several slides in here, I'm going to share a link with you and a couple of examples of some auditing checklists that hospitals have used in the past, and they've been willing to share those with us, and we put those up on our website for people to use and adapt for their own needs. And those are just in a Word document, but they could easily be, you know, created in some sort of electronic format if that's what you wanted to do. So, okay. Okay, so getting back to, thanks for the question in the chat, and please, if things pop up as we're talking, we're very informal here and are quite willing to stop and answer those questions, because we want to make this very useful for all of you. But we thought it was like, well, before we dive in too much, let's just define what we're talking about with auditing. And so a definition of auditing could be this: a systematic process to obtain evidence to verify that activity is being conducted in compliance with policies and procedures. Basically, we want to know, are we really doing what we say we're supposed to be doing for a given patient? So auditing the care processes that are supposed to be in place. In a few slides here, you'll also see that we can also audit the environment or our equipment, and making sure that the environment is safe and the equipment is functioning. Those are some other things that can be audited as well. Some of the why, well, we want to give our patients good care. We don't want things to fall through the cracks. And so we're trying to establish consistency of processes that helps hardwire behaviors in our staff. And I've already kind of alluded to the fact that it gives you another measure of how successful your program is beyond just waiting for those fall and fall injury rates to occur. And some other comments about auditing, and we all want to do the right thing for our patients. And, Amber just commented on something, an example of like self-auditing is just doing a chart check. And, do I have all of the things that I need to have documented? Are they documented before I leave my shift and hand off that patient? So we can certainly self-monitor and self-assess. But we're human and we make mistakes. And so sometimes it is nice to have somebody else helping with a fairly objective process. And it's not that you're necessarily trying to catch a colleague or somebody who works under you. If you're like the nurse manager and you're auditing the bedside staff, you're not trying to catch people, and catch them in mistakes. You're trying to, learn what's working. And a lot of times these audits will identify kind of more team issues or hospital-wide issues that need to be addressed. It's not always about trying to catch somebody doing something wrong or slipping up. It's absolutely not that. We want to try to not let the messaging about the auditing program, kind of trend that direction. It's about improvement and providing quality care, and that's everyone's responsibility. And we're all human, and sometimes we miss things and make mistakes. The how we audit, that's again what we're here today to talk about. So I'm sure there's a lot of quality improvement people on the call today. And so the Donna Bedian's quality framework is probably something you're very familiar with or at least heard about before, but it lays out structures, processes, and outcomes. So structures being like the tools we have at our disposal. And so that might be the people, that might be our equipment, that might be, aspects of the EMR, for example. The processes are the things we actually do. So actually conducting that risk screen, actually, having those interventions in place and delivering those interventions. Whatever steps need to occur after a fall occurs, those would be examples of processes. And then our outcomes, of course, are those fall rates and fall injury rates. The auditing is going to be looking at these two aspects of Donna Bedian's framework. So are the structures in place, and are we conducting our processes according to our policies and procedures? More information to convince you why you should do this. This is some data from one of the very first cohorts of hospitals that went through the Capture Falls program. And that was kind of like a prolonged 2-year kind of gradual improvement of their fall risk reduction program. But at the end of those 2 years, we asked hospitals to rate how effective they felt that they were at conducting audits. And it was a questionnaire that was very similar to the gap analysis that you just completed, except we had them rate the effectiveness like on a 5-point Likert scale. And for those hospitals that felt that they did a pretty good job at that, they rated themselves as being effective or very effective. That's in the green. Okay, so these are the fall rates on the y-axis. They had lower total unassisted and injurious fall rates than the hospitals who felt they were only moderately effective or even less than moderately effective at conducting those audits. So this is some real world data from some hospitals in Nebraska showing how, it implies that fall rates are potentially related to how well you're doing your audits, because again, those structures and processes are going to affect those outcomes downstream. All right, so now we have a series of slides in here where we're going to be showing you some suggestions from some reputable organizations. And two of them are from the US government, the Agency for Healthcare Research and Quality, which is actually part of the National Institutes of Health, and then the Department of Veterans Affairs. And then we also have the Victorian Quality Council. This is an Australian organization, and I would say Australia as a whole, they kind of have it going on with fall risk reduction. And there's a lot of research that comes out of Australia and a lot of good resources that come out of Australia as well. And so there's several slides that are set up like a table like this, where we go through the what and the who and the when types of questions, and lay out what these resources are suggesting is done. So we've got a lot of slides that look like that. And sprinkled in between those are some gap analysis data, the answers that you guys shared with us on your gap analysis in aggregate. And then towards the end, we have some real world practical examples of things that we've that have worked well with hospitals that we have collaborated with in the past, things that they've told us that have worked really well, that I think really echo what Amber shared with us earlier. Okay, so what do these agencies and organizations say about what you should audit? Well, the Agency for Healthcare Research and Quality, they focus a lot on the processes. So completion of that fall risk assessment tool on a regular basis, delivery of those interventions, completing the right paperwork if a fall actually does occur. And then the VA and the Victorian Quality Council, their suggestions are focused more on the environment and the equipment that our patients might use. So making sure equipment is functioning and safe. So does that call light work? So if you're gonna, or if you're gonna put a bed alarm on a patient, making sure that bed alarm works, you know, if that is a needed intervention before you walk out the door. Making sure the environment in general is safe, you know, devoid of clutter, adequate lighting, and so on. The Victorian Quality Council kind of takes that environment and divides it even a little bit further of thinking about any individual patient's environment. So making sure, for example, that the bedside chair fits the patient well. So that they're able to get in and out of that chair safely, for example. Or if you're going to be moving them in a wheelchair, making sure all the wheelchair parts are functioning well. So taking a scan of that patient's individual environment and equipment. And then they also talk about just the environment of the hospital in general. So, you know, is the railing in the hallway loose, or does it need to be fixed? You know, do we generally have clear walking paths for our patients? Is there adequate lighting in the bathrooms, and so on? And so looking at the environment more generally, not necessarily in the context of a specific patient, but in the context of everybody, quite frankly. So that's what those three agencies suggest in terms of what to audit. This is what you guys are auditing. So of the 14 hospitals who are currently doing audits, you're auditing a lot of the same things. And so high percentages of you are auditing whether or not the fall risk reduction tool, like the screening tool, is completed. You're auditing how well you're delivering your interventions. You're auditing equipment and environment, and completion of post-fall documentation. And then one hospital, 7% is one hospital out of 14 filled in the other, and they said that they audit care plan updates. So if something changes in that patient's plan of care, is that actually happening, is how I understand that. So you guys are auditing the things that the experts are saying should be audited. Okay. Who should conduct the audit? So this is, again, what these three reputable resources are suggesting. And for the most part, it's kind of leadership is who they're suggesting conduct the audits. And so unit manager or unit champion, so that might be somebody on the unit or in your hospital who's maybe the lead of your fall risk reduction team. We could interpret it that way. The VA says management staff, but they also say nursing. And so I would interpret that to be, you know, floor nurses. And Amber spoke to the benefit of having kind of those frontline staff do it, not always somebody in a management role. Victorian Quality Council suggested that, again, they were very focused in on making sure everything worked for that individual patient. And so that's the patient, that's the nurse who's admitting that patient, is making sure that the environment and equipment is adequate for that given patient. And then I have to chuckle at this. For the general and hospital environment, they just say person in charge of the area. Well, that's probably the unit manager or the charge nurse, or maybe it's facilities staff that is going through and making sure that things are safe in general, and lack of trip hazards and slip hazards and so on. So in terms of which patients to audit, Agency for Healthcare Research and Quality says it's okay to just pick an arbitrary number. Their audience is all sorts of hospitals of all sizes. And if you're a very large hospital, it's not necessarily feasible to do an audit, especially if you're kind of looking at your fall risk reduction processes in general. Probably not feasible to audit every single patient every single time. And so you might want to just take a snapshot. Now, if you are a small critical access hospital, it might be feasible to audit every patient on the floor, maybe not every single day, but like say if you want to see how regularly are we using gait belts for patients who need assistance with mobility. Well, that is a situation where maybe once a month you go ahead and do the entire census of your hospital, again if it's relatively small, and do a spot check of that once a month to see how things are going. So again, you don't necessarily have to do every single patient every single time, especially if you're looking at the conduct of those processes. Some regular time intervals that are reasonable would make sense. And if it's something new, like what Amber said, she talked about auditing some new processes. Those are something that maybe you do want to audit a little bit more frequently, at least at first, until things start going well and kind of have become ingrained in your staff. Okay. The VA, they don't even comment on exactly which patients or when to audit them. And then the Victorian Quality Council, looking at that individual patient's environment, that should be done. They suggest every patient upon admission, but because that environment can change, clutter probably grows the longer a patient is in the hospital. And so that, I would say, is something that needs to be scanned in the room almost every time somebody's in there to make sure that there's no trip hazards or anything like that. And then in terms of the general hospital environment, they just suggest regular intervals such as monthly to make sure light bulbs aren't burned out and so on and so forth. This is when you all told us you were auditing. And so of the 14 of the hospitals that are auditing that completed the gap analysis, roughly a third of you are doing it at least monthly. And then fewer people are doing it at slightly longer intervals. And then a lot of people filled in other, and that description there was daily, sometimes weekly, sometimes just at admission, or it was just kind of random and inconsistent. So there was a variety of answers there. Getting into how to audit, hands down using a checklist, some sort of objective list of items that you want to make sure you look at every single time. So every resource here is suggesting a use of a checklist, and I'll show you some examples here in a little bit. The Agency for Healthcare Research and Quality, and really all of them, I guess, also comment on direct observation of care. So, you can go to the chart and see what is charted in the care plan. But we all know that sometimes what's written down isn't necessarily what's happening in practice. So, for example, I'm a physical therapist, so I'm going to use the gait belt example again. But if our care plan says we should be using a gait belt every time that patient is up and moving around the room, then that's what the care plan says. We can audit the chart, but then, it'd be great to have eyes on staff and make sure that that's actually happening. And so being a fly on the wall and observing what's going on the floor and being able to actually see that those interventions are being delivered as they are written in the chart to be delivered. So all three of these mention direct observation of the delivery of care. And obviously, if you're going to check out equipment and environment, that also has to be done with direct observation. Okay. Whether or not something like the fall risk assessment tool is being done, well, you can go to the chart and find that. So looking at the medical record. And then also surveying staff, you aren't going to necessarily, be able to observe, at the moment in time that you're doing the audit, you might not observe something. And so simply asking staff about how things are getting done is another way that you can complete that audit checklist. Okay. So now that kind of concludes the what and the who and the when and the how from our three governmental agencies. And so this slide now gives you some very real world practical examples of what hospitals in Nebraska, and this was specifically some critical access hospitals in Nebraska, what they do for auditing. And again, I think some of this mirrors what Amber was sharing earlier. So the things that hospitals in Nebraska that we've worked with in the past have been auditing really mirror the things that the experts have recommended: the fall risk tool, the care processes such as the interventions, particularly new ones. Again, if there's a new policy that you want your staff to follow and you roll out that policy, you educate everybody on what the expectations are, doing an audit to check in to see how that is going is very useful, because it might need some additional reinforcement. Maybe workflows need to change in order for it to be able to actually happen. Those kinds of things can be discovered in an audit. People in some of the hospitals in Nebraska were actually interviewing patients and families, and that is a way to help determine the effectiveness of patient education, for example. So actually having a conversation and kind of interviewing those patients and families. Anything that is uncovered as a concern, either on past audits, or if you're seeing some trends in your fall events, it's like, okay, we're not doing X, Y, or Z very well, and people are falling. Well, that might be something you want to put on your list of things to audit. So you don't have to audit like every possible thing every single time. You might want to pick and choose, things that seem really important or things that appear to be gaps in your program. Identified with fall events, or again, something new. And then of course, environment and equipment. Okay. Vicki just put a comment in the chat here. She says you can also consider gathering feedback from patients and or families on their understanding of or experience with fall risk reduction practices. Vicki, do you want to, I see you're unmuted. Do you want to add to that?
I had put that in there from the previous slide, because I forgot it was on this one. So you have that part covered.
Oh, you got my back to make sure I didn't miss anything. Okay, who to audit? A lot of the hospitals, it wasn't necessarily the charge nurse on the unit, but it was various members of the hospital-wide fall risk reduction team. So, you guys have all formed teams, and so, presumably there's nursing on your team, quality improvement. It's great if you've got rehab representation, PT or OT, or both, maybe pharmacy. And so it can be any of those players can spend some time on the floor and be conducting these audits. And I love Amber's suggestion of having it be peers of the floor staff, because then it maybe seems less punitive, and it's like you're there, you have more buy-in, and everyone just has each other's back, and you're helping each other deliver good care. I mean, that's really what we're trying to accomplish. Again, we're not trying to be punitive or catch anybody in a mistake. In terms of which patients to audit or when, most of the hospitals we've worked with just have selected a random sample of patients, and how many that is, again, depends on your hospital size and what your census is at the time, as far as what is feasible. I would also say, it makes good sense to audit specifically those patients that were identified at fall risk, but remember that almost every patient that enters our hospital doors is at fall risk. And so we have universal fall risk interventions, such as making sure the call light's in place and reachable, good lighting, top bed rails up. Those are things that we do for all patients, regardless if they're at risk or not. And so you might want your sample to include both patients at risk and not at risk, because you want to look for those kinds of things for everybody. Not every intervention, if you're auditing bed alarms, well, that might not be relevant to all of the patients you audit, but some things certainly are relevant to all of the patients you audit. Okay. And then how, again, everybody's using a checklist just to guide their audit. And one of the examples I'm going to show you even has like an instruction sheet on how to fill out the checklist, specifically what you need to be looking for, which is really helpful if it's not the same person doing the audit every single time. And then again, depending on what is being audited, sometimes you can just look at the chart. Sometimes you actually have to have eyes on an event, or sometimes you can just ask people, interview the patients or staff. Okay, so here is, I've got this open here. So let me pull this over to my other screen here. So this is the link that, whoops, I lost it. There we go. This is the link that's on the slide that takes you to our fall audit tools. And let me just get my little pointer. Okay, so these four here, these example process audit tools, these four are example audit tools or checklists from hospitals that we have worked with in the past that we felt that these tools were particularly good, and asked these hospitals for permission to post them on our website. And so they gave permission for us to do that. Some of these other resources here are for some, other sources like the Agency for Healthcare Research and Quality, the VA, the Institute for Healthcare Improvement. And so there's other, examples of checklists in these resources that you can look at. As I was getting ready for this talk, I literally just Googled fall auditing checklist and other examples come up on the web. And so there's a lot of examples floating around there. I would say there's not one or that's necessarily any better than the other. I would just pick one or pick one and tweak it to meet your needs, to make sense with your data and your processes. I think just the fact of you're doing auditing in and of itself is a great thing. And long as you have a checklist to guide, it doesn't necessarily matter what that checklist looks like or how it's structured. So I do want to show you a couple of examples. So let me pull this over and make it bigger. Okay. So this is an example from one of the Nebraska hospitals that we've worked with in the past. And so you can see here that, there's different columns. And so you could, on any given day, audit several patients, all on the same day. So you put in the room number and the medical record number, reviewed by, this would be who is doing the audit. And then they have the list of things here that these are what they were auditing. And again, what specifically you would choose to audit might depend on what you identify your biggest needs are, or what you might want to what you really want to be looking at. You don't have to audit every single one of these every single time. Okay. I think if I would improve this tool at all, I would maybe consider adding a not applicable column for these, because, like, for instance, not every patient's going to need a TABS alarm. Not every patient uses a walker or assistive device. And so, if I say no here, is that no, and really it should be in place, or is it just purely not applicable to that given patient? So that might be a little bit of room for improvement on this one. But the other thing I really like about this one here is that they have an instruction sheet. So this is, again, if there's going to be multiple people doing audits in your hospital over a period of time, this helps make sure that everybody is looking at the same thing. So that was one example that I thought was good. And then here's another one. Let me pull this over. So just kind of similar thing, so this, you could extend this form, out and add pages to add more patients if you chose to, but this form had a little bit of context where they actually entered the fall risk score. So you kind of had some context of how high of risk a given patient was. And then again, a lot of, processes, a lot of interventions that we would be putting in place to reduce a patient's fall risk. And then the other thing I wanted to point out about this particular one is that this version actually shows kind of how you might even share the results, an example of how you would present the results. And it can be pretty simple math. It's just like, you know, out of X number of patients who should have had this in place, what percentage of patients actually did have that in place? And so, for example, false history assessment on admission. Well, we did that this hospital did that for 92% of the patients. There was evidence of that in the medical record, and missed it on 17%. They had done a dozen patients in November is what they chose as their audit sample. So those are there on the web for you. Again, there's four examples. And again, literally you can Google and find other versions and other formats. You know, I would encourage you to kind of pick one and kind of make it your own. All right, so now what do you do with the results? So this is, I'm going to kind of foreshadow Vicky's content and then turn it back over to her. As she's the industrial organizational psychologist on our team here. And so she's really good about this, the team aspect of fall risk reduction, which is kind of what this is. This is getting the information back to your staff. So this is what the three organizations suggested. Agency for Healthcare Research and Quality merely said you should reflect on whatever barriers that might be in place for you know, getting the processes done and develop a plan to fix it. The VA didn't really address what to do with the results, and the Victorian Quality Council made the point is if you find an issue for a given patient, it'd be good to fix that right away. So like, for example, you know, if there's not a gate belt in the room and there should be, get one in there so that it's readily available for staff for that individual patient. So you kind of have to address any gaps right away. Here is what you guys are saying about communicating audit results to your staff. So again, this is out of the 14 hospitals who actually are conducting auditing right now. About a third of you felt like you were doing a pretty good job getting that information back to staff. A lot of you thought you could do better, and then one hospital wasn't getting that information back to the staff. Okay, Vicki, I'm going to give you control of the screen and let you take it from here then.
Sounds good. Thanks, Dawn. So as we've been talking a lot about the auditing process, one thing to keep in mind is that at least in some of the evidence base and other resources, we call this auditing and feedback. So sometimes we do a great job with the process of collecting data and doing the audit, but we have to close the loop to some extent with our staff members, with the team, with the department of interest, and make sure that we provide feedback to them about what we have learned from our audits and help to generate some goals and develop a plan to improve performance. So there's several kind of decision points and things for you to think about when we're trying to decide what to do with the audit results. Obviously, you need some time to analyze and interpret the results of your audit so you can make sense of it before you start to feedback that information to the target of the audit. A couple other points you want to think about is thinking about how you want to share the data and the results, whether that's in writing, whether that's verbally, or some combination of the two. And a best practice from the evidence base is to provide some sort of comparison data. So how are you comparing, you know, how do these results of the audit compare to others? How does it compare to target goals we have set for our organization? Or how does it compare historically over time? So did we do better this time compared to the last time we had conducted an audit? Thinking about who will share the data and the results. We'll talk about some of these in a little more detail on the next slide, when to share them, and then offering some time to reflect on and discuss some of the potential reasons for successes and for gaps. Especially if something surprises us in our data, we might want to dig a little bit deeper to try to understand what are all the reasons why we perhaps weren't as successful with utilizing gate belts, to continue with Dawn's example, you know, compared to what our expectations and what our policies and procedures say. And then finally, generating goals and developing a plan to improve performance, which will then present an opportunity for us to audit in the future to see if we've actually achieved those goals and made the progress that we intended. So a couple, kind of to summarize some additional best practices for auditing and feedback interventions. It's essential that the information you're collecting in your audit is perceived as valid and credible by the recipients of the audit results. So people will tend to perceive that audit as more relevant and accurate and useful when they think the data is credible and it's meaningful to them. I want to focus mostly on the feedback components of this because we haven't talked about this in too much detail. So what we know from the evidence base is that feedback is most effective when it's presented both verbally and in writing. So you can think about how you might create some sort of documentation, but then also have a follow-up conversation or have a conversation while you're sharing that information with others. And consistent with Amber's experience, the feedback can be most effective when the person who's delivering that feedback is a supervisor or a trusted colleague, rather than someone who is unknown to the individual. Providing that feedback in person can also give you an opportunity to tailor the messaging to the recipients of the feedback. So you may have a sense of how well a particular individual or a department might respond to feedback on their performance. So you can kind of take that and keep that in mind as you decide how to tailor that messaging about how those individuals, teams, or departments have been performing. We want the feedback to describe behaviors that we ideally desire by the recipient, and that can actually be implemented by the members of the team who are responsible for changing their behavior. So one thing we can do is provide some sort of comparison data as a means to help motivate the recipients to change their behavior, especially if what we're finding from the audit is significantly below the bar we have set for our organization or for our target goals. When we get feedback as an individual that indicates there's some sort of discrepancy between our expected performance and our actual performance, sometimes individuals can experience what we call cognitive dissonance with that. So in that case, the participants might try to reduce that discrepancy by either planning to change their behavior and improve, or they might try to discount the data or the goals that you're setting as totally invalid. Not something I want to deal with. Like I don't agree with any of your auditing data. So really thinking carefully about how you design that feedback to help minimize overly emotional responses or defensiveness can be helpful. We really want to shift that recipient's attention toward specific achievable tasks and behaviors that they can do to help us achieve the best outcomes for our staff and for our patients. And then finally, setting goals through the feedback process is important because goals can make that feedback a little bit more salient, and creating an action plan or some specific steps along with that can be helpful so that individuals see some concrete behavior changes that can be made in order to achieve the goal we're intending. So the more specific the goals are, the more this process can be effective. So ideally, you probably have heard of the acronym, the SMART goal. You can have specific, measurable, achievable, relevant, and time-bound goals to help guide an individual as they're synthesizing this feedback and thinking about how they'll change their behavior. That can really provide a nice platform to help us move forward. And it will give us something concrete to refer back to when conducting the next audit. Dawn, did you want to talk about this slide, the additional resources?
Sorry, it took me a minute to unmute. Yeah, this is just links to the 3 resources that were on those slides with the table, just links to the direct documents there. And so I've got a little bit of text here, like especially in the VA and the Victorian Quality Council documents about like specifically where you want to go within those documents, because they're bigger than just auditing. And then in the ARC toolkit, I actually, that Royal College of Physicians out of London was actually the source that ARC cited when they were talking about auditing. So I also gave the link to the original source for you. So that's all I need to say about this slide.
Sounds good. In terms of other resources, we have a link here to an open access resource on auditing and feedback. This is published in the Cochrane database of systematic reviews, which is a pretty reputable resource to go to for systematic reviews of literature on various healthcare topics. So many of the tips we've shared with you today, in addition to other information and tips, can be found in this as well. And again, this is open access and freely available for anyone to utilize. We're coming up here on time, pretty closely on time. I want to make sure we have a chance to go through kind of our wrap up and our to-dos before the next session, in part because the next session will provide ample opportunity for Q&A and technical assistance as you work on developing your auditing processes and tools. So to wrap up our session today, we've dumped a lot of information, on you about auditing, but hopefully I've given you some concrete ideas to think about how you might set up an auditing process and system, and how you might start to develop some of those tools you'll use to collect data and how you might deliver feedback. So we'd like for you to do in preparation for session number 4 is to decide what would you like to audit that's related to fall risk reduction within the next month. We don't want to dictate what that topic is, because we know that from what many of you have learned from your gap analyses, there may be different processes or practices that emerge as something that would be beneficial to take a look at further. So we'd like you to decide what you want to audit within the next month. Explore some of the auditing tools, examples that we have provided. If you have your own tools, you can revisit those, and maybe it's a good time to revamp what those look like. Or perhaps even utilize or find other tools you'd like to select or adapt to use for auditing. Third, come up with a plan for who will conduct the audits or who will participate in the auditing process within your facility. And then join us on September 16th, which is session number 4. If you'd like some consultation, help, assistance, you just want to talk through any of the above we have listed here, that we'll talk about that more in a second on the next slide, but that'll sort of be an open working time, you could say, to provide expertise and resources to support you as you're developing your auditing processes and tools. And then in preparation for session 5, which is at the end of the month, we'd like you to conduct an audit on whatever topics you have chosen, and be prepared to share that experience with us on September 29th.
Not your audit data necessarily, but just how did it go?
Right, yeah, your experience. Yeah, we don't need a formal report or anything, but just more about the experience, thinking about it through the model for improvement as a way for it to say, like, here's how the first round went, what went well, what didn't go well, what could we do differently next time? And we can utilize that time as well to provide additional support to you. So for our next session, it's considered an optional session. We're thinking about it as like technical assistance time. So we encourage you to join us, but we'll use this opportunity to support you, provide guidance to you, opportunity for collaboration and discussion as you're working on your auditing tool and process, whether you're starting from scratch, refining an existing tool, or adapting one of the tools that we've shared with you today. I think, were we still hoping to have people RSVP to kind of let us know, just so we can get a sense of who might be attending the session?
Dana, what do you think? We were debating about that, if we wanted to get RSVPs just so we knew kind of how many people would come and maybe what their questions were ahead of time. Is that
I
feasible?
think that would be great. And I can send out maybe just a short email, kind of just getting an idea if participants want to join, and maybe just feedback on what they're wanting to discuss. So then we can go in prepared for at least some structured learning. And then if that opens up to more questions, we can go from there. But I can shoot an email out to those that are on my distribution list and just kind of get a feel for what people are maybe struggling with or have questions on, or what we can support them in.
Yeah, that sounds great.
Okay, perfect.
In the meantime, if you have questions as you start working on your, assignments or to-dos for the next session, you have our contact information here. So don't feel like you have to wait until the technical assistance, call if you have a question you'd like addressed or help you'd like sooner than later. But also, plan to at least RSVP or join us for the session, the optional session here on the 16th. So we can continue to support you as we focus on auditing. And with that, I'll turn it over to you, Dana.
That was so good. Thank you, guys. And I think that all of that information could be used across our quality work as we try to change processes, improve processes, hardwire processes, those kinds of things. So yeah, take those tools and really you can use them across your work. So we are past 1 o'clock, so I won't keep anybody any longer. But if you have questions, don't hesitate to reach out. Watch for an email from me regarding technical assistant and questions. I'll probably give a little time just so you can do some of your homework before and see what questions you come up with. Otherwise, we'll let you get back to your day. Holler if you need something in the meantime. And thank you, everybody, for joining us today.